To really understand this and to put it in perspective, I want to spend the first 5 minutes talking about atrial fibrillation as a vascular disease. And this concept put forward here some time back by myself and Dr. George Wise really illustrates, let me just show you, the slide has got a little distorted, but I really think of atrial fibrillation as two conditions. To the left, you have atrial fibrillation primarily triggers lone atrial fibrillation, genetics mediated by vagal tone, and on the right you have a diseased atrial substrate, the result of age, obesity, and atherosclerotic risk factors. These are the patients with paroxysmal atrial fibrillation who respond to pulmonary vein isolation, and these are the patients with permanent and persistent atrial fibrillation. And most of the population with atrial fibrillation over the age of 70, 75 have this kind of trigger and disease substrate. Now, atrial fibrillation as a vascular disease is illustrated here, and what I'm summarizing in this one slide is about 20 years of work in which we've concentrated on factors initiating atrial fibrillation as a vascular disease. Shown here on the left, we know that obesity, hypertension, metabolic syndrome, and sleep apnea, we know that they are strongly associated with atrial fibrillation. We also know that left atrial volume and diastolic dysfunction is strongly associated with atrial fibrillation. What we've also shown in a series of studies is that obesity, hypertension, metabolic syndrome all cause increased arterial stiffness, diastolic dysfunction, and increased left atrial volume. And therefore, although we haven't proven cause and effect, there's strong association between these conditions, arterial stiffness, diastolic dysfunction, and atrial fibrillation. It's very difficult to prove that sleep apnea alone is a cause of atrial fibrillation and diastolic dysfunction because it's difficult to separate out sleep apnea from the other factors, namely obesity, hypertension, and metabolic syndrome. Increased left atrial volume, there are a number of factors that play a role in the increase in left atrial volume. And the question is left atrial volume increase a cause or a surrogate of atrial fibrillation, or both? But clearly, in the vast majority of people, it's a vascular disease. Now, this is a meta-analysis of stroke from 5 randomized trials in which the placebo stroke rate was 4.5% per year. These are the old trials of warfarin and placebo. And if you look at the risk factors for stroke, they're shown here. Previous stroke, hypertension, advanced age. All of these are age-related, which is why the risk of stroke goes up in older people with atrial fibrillation. But I want you to contrast that with these data from the New England Journal that we published years ago. Patients under the age of 60, no risk factors, and their stroke rate was less than 1% per year. And these patients here, somewhere around 4 to 7% per year. But they had the same arrhythmia, atrial fibrillation. So what this tells us, it's not atrial fibrillation alone that's causing the stroke, it's the company it keeps. And this, I think, is very striking evidence for that. So there are many explanations for the association between AFib and stroke. Atrial fibrillation causes diminished left atrial appendage flow velocities, atrial dilatation, stasis, and here's a thrombus in the left atrium, obviously the left atrial appendage. And the implications of this hypothesis is that the atrial fibrillation precedes stroke, elimination of atrial fibrillation will prevent stroke, and left atrial appendage closure may prevent stroke. But there's another concept, and that is atherosclerotic risk factors, age, and genetics cause vascular inflammation and injury and fibrosis. This in turn causes diastolic dysfunction and atrial myopathy, which is primary or secondary, characterized by dilatation of the left atrium, fibrosis. All of this would precede and lead to atrial dilatation and thrombus. And in this situation, AF is a marker of vascular disease burden. The left atrium also mechanical and electrical dysfunction. And under this concept, endothelial dysfunction, both atrial and atrial appendage and vascular, may in itself be hypercoagulable and lead to left atrial thrombus. And of course, what's important about this concept is it's a systematic or system disease, and simply eliminating the left atrial appendage will not cure it. Left atrial may reduce, but it won't eliminate the risk of stroke. Now, what about the CHADS-2 and the CHADS-VASc risk scores, all of which, I don't know why some of these slides are somewhat distorted. Have you any explanation for it? I don't know if it's a mismatch between my system and what you're using there, but these slides are distorted in any way. The CHADS-2 and the CHADS-2-VASc risk scores are shown here. It hasn't come out on the slide, but the guidelines basically state with a CHADS of 0, you do not need to anticoagulate. CHADS-2 or CHADS-VASc2, you must anticoagulate. And with a CHADS-VASc of 1, there is some controversy. We have got a problem. My slides are being distorted. I'm not quite sure what to do. They looked fine when we ran through them, but somehow the system is distorting them. I'll see what I'll do my best. But these yellow, orange, and green bars are meant to come out below the slide. But in terms of the contemporary risk stratification schemes, shown here are a whole series of them. The study on the left, and then the yellow is the performance, low frequency, intermediate, and high frequency, and on the right is the C statistic. Now, what I want you to look at is this. The range of the C statistic. Now, the C statistic tells you a bit about the predictive value of the score. Now, a C statistic of 0.5 is like flipping a coin, heads or tails. But a C statistic of 0.549 to 0.638, all of them perform very poorly, and that includes the CHADS-VASc score. So the first point I'd make is that the CHADS scores are helpful, but they are not very accurate. Now, this is a study from our institution about the CHADS-2 score, a case control study, 110 patients with non-valvular atrial fibrillation and left atrial appendage thrombus. We underwent TEE. And what you can see is basically the distribution of scores. Was we looked at controls and cases that had thrombus in the left atrial appendage, and basically what we saw was if this is the CHADS score here, there's considerable overlap. So the point I would like to make is the CHADS-2 score and the CHADS-2-VASc score do not measure left atrial thrombus. They're associated with it, but they're not a direct index of left atrial thrombus. They're an index of vascular disease. Now, this is the CHADS and the CHADS-2 as predictors of adverse events. Now, in this series of studies of patients with and without atrial fibrillation, the CHADS-2 score and the CHADS-2-VASc score identified high-risk cardiovascular outpatients. In patients with acute coronary syndromes, without atrial fibrillation, the CHADS score predicted adverse events. In patients with atrial fibrillation undergoing PCI, the scores predicted adverse events. In post-STEMI patients at high risk of AF and stroke, even without AF, CHADS-2 and CHADS-2-VASc predicted events. And the risks of stroke late post-CABG. So the CHADS-2 and the CHADS-2-VASc scores are not unique to atrial fibrillation. They predict vascular disease. And this is a rather nice example of the ability of the risk scores to predict, shown in yellow, the recurrence of atrial fibrillation after radiofrequency ablation. And both the CHADS-2 and the CHADS-2-VASc predict recurrence of atrial fibrillation after radiofrequency ablation. So the CHADS-2 scores, we use them with atrial fibrillation, but we have to understand they predict risk, vascular risk. Now, in the Danish study, here are 47,000 patients with a CHADS score of 0. This is the hazard ratio for an event on this axis. And if you have a CHADS-2 score of 0, but a CHADS-2-VASc score of 1, shown here, then the risk of events is considerably increased. So the value of the CHADS-VAS score, it takes low-risk patients with the CHADS-2 score of 0 and can identify a higher group. In those with a CHADS score of 1, if the CHADS-VAS score is also 1, it's equal to the CHADS score, but if the CHADS-2 score is 2, that shows a much higher risk than a CHADS score of 1. So there is a value to the CHADS-VAS score in identifying very low-risk people, and some people with the CHADS score at low risk are clearly at high risk. But what you need to remember is that the risk factors for thromboembolic events in the CHADS-VAS score are shown here. And the size of the circle is the hazard ratio estimates and the weight of the individual risk factor. And the point I want to make is not all one-pointers are equal in the CHADS-VAS score. The most important predictor of those factors that have a score of 1, the most important predictor is age 65 to 74 years. And in fact, if you look at the other risk factors, history of heart failure, diabetes, vascular disease, being female, on their own they're of very little value. The CHADS-VASc is really driven by prior stroke, and if you just look at the one-pointers, it's by age. So this is very controversial. Everybody agrees that we should anticoagulate with a CHADS-VASc of 2. And everybody agrees that we should do nothing with a CHADS-VASc of 0. But what about a CHADS-VASc of 1? So this study from Taiwan, annual stroke rate in these patients was 2.75 and 2.55 per year. This study suggested that the CHADS-VASc 1 was a powerful predictor. This study from the Swedish National Registry is very different and a very important study because they excluded people with valvular disease. What they also did was, for the first time, Freiberg looked in yellow at transient ischemic attacks, pulmonary embolism, and in blue is the incidence of ischemic stroke. And in this population, with a much, much lower rate of ischemic stroke than in the others, you can see here that with a CHADS-VASc of 1, the stroke rate, the ischemic stroke rate, actually is under 0.5%. And they say that to justify warfarin, you have to have a rate of 1.7 or 0.9%. So in this Swedish study, in fact, with a lower risk of stroke, the CHADS-VASc 1 didn't justify anticoagulation. And what one also needs to appreciate are the 3 major studies in which the CHADS-VASc has been looked at. In Denmark, the original study that really drove the ESC guidelines, stroke rate in this population, 2.0%. In Taiwan, the stroke rate was 2.7 and 2.5%. And in the Swedish population, this is men and women, the stroke rate is 0.5 to 0.9%. So there's a paper now in press that's going to make a very strong case for not anticoagulating with the CHADS-VASc of 1. And I think what it really depends upon is the underlying risk of the population. So if you have a population at a higher risk of stroke, probably it's a good idea to anticoagulate everybody with the CHADS-VASc of 1. But in those with a lower risk of stroke, like in Sweden, it didn't hold up. And this remains controversial. Now, this is a study that we have now in press. It's interesting. We have access to 100 million people, enrollees in a large insurance company database. And 64,000 patients were looked at in this study. These were patients on warfarin, dabigatran, rivaroxaban, and apixaban. And what we really looked at in this study was whether or not they adhered to their therapy. And it's a very worrying study because just like with warfarin, about 40% of patients discontinue their anticoagulants. But what is interesting is to look at those in blue who discontinued anticoagulants at least 6 months before. And what you see is the following. This is the rate of stroke or systemic embolism in CHADS-VASc of 0 to 1, 2 to 3, and 4 or more. And shown here is the, if you just look in the areas that are highlighted, you'll see that if they had a CHADS-VASc of 0 or 1 and they discontinued anticoagulants, there was no increase in stroke or systemic embolism in this United States population. But if they had a CHADS-VASc of 2 or 3, or 3 or more, and they discontinued anticoagulants, they had almost double the risk of stroke. So further evidence that at least in our population, a CHA2DS2-VASc of 1 may not be high risk. So just when I knew all of life's answers, they changed the questions. And let me show you some data that changed the questions. 13,000 patients in the Aristotle trial, which was the trial of apixaban versus warfarin. And in this trial, we have a biomarker sub-study, thanks to Dr. Lars Valentin. And what I want you to look at, to the right of each slide in blue, is the highest quartile of high sensitivity troponin T, and here is the CHA2DS2-VASc score on this axis. So if you take a CHA2DS2-VASc of 1 or less, CHA2DS2-VASc of 1 or less, stroke and systemic embolism and cardiac death, the CHA2DS2-VASc score is completely overpowered by high sensitivity troponin, a much more powerful predictor, and also a predictor of of major bleeding. The other biomarker that we looked at was NT-proBNP, and you can see here the CHA2DS2-VASc score 1 to 5. In each category, NT-proBNP is a powerful, powerful predictor of events. So the independent relationship between high sensitivity troponin and events, it's very clear cut, and we published this in about 5 papers. We don't really understand what it means though. I mean, high sensitivity troponin is a marker of myocyte stress, apoptosis, necrosis, aging, tissue vulnerability, comorbidities, ischemia, myocardial dysfunction and remodeling. It's a marker of inflammation, fibrosis, a hypercoagulable state, endothelial dysfunction, increased myocyte turnover, cellular integrity, and permeability. What the biomarkers are going to tell us is a great deal about understanding atrial fibrillation. They may not help us clinically at the moment, but the fact is, high sensitivity troponin overpowers the CHA2DS2-VASc score as a predictor. With BNP, it's a little easier to understand because BNP is a marker of LV size and function, LV filling pressures, renal function, age, and sex. And certainly the BNP is a function of atrial function and atrial pressure. So I think it's easier to understand perhaps why BNP is a powerful predictor, and not so easy to understand the troponins. But the fact remains that high sensitivity troponin is a very powerful risk factor. So where does this go in conclusion? Here is a schematic of atrial fibrillation, LVH, hypertension, thrombus in the left atrial appendage, vascular disease, atherosclerosis, inflammation, and a prothrombotic state. Where do the biomarkers fit in? And in fact, we have a whole series of studies that are ongoing right now, some in press, looking at CRP, cystatin, interleukin-6, BNP, inflammatory markers, prothrombotic markers, and all of these tell a story, and we still have to put the chapters together. But there, as one understands the postulated schematic of thromboembolism and stroke and atrial fibrillation, you can start to see where these biomarkers come in, and we have a great deal of understanding to do. We've demonstrated it, but we still have to understand it. So future prospects, I think the biomarkers may predict responses to drugs and ablation, assessment of bleeding risk with new oral anticoagulants, perhaps genetic markers for tailoring of the dosage of warfarin. Will they predict? I'm sure that with time, as we understand the markers and proteomics and the biological systems of disease, we'll have a much clearer idea of the pathophysiology of atrial fibrillation, new drug targets, and the allowance of early disease detection. But we really have a great deal, and that's the point of this talk, more to do to understand the pathophysiology of atrial fibrillation. So my closing slide is this: the limitations of risk stratification scores for atrial fibrillation and stroke. First of all, the atrial fibrillation population is very heterogeneous regarding stroke risk. It's not one population. They are multiple populations. The problem has been that different classifications in measuring stroke rates lead to overestimates. An incorporation of other embolic episodes, including pulmonary embolism and systemic thromboembolism, confuses the issue, and I think the Swedes have been absolutely correct in that they focused on ischemic stroke risk and not allowed the data to be tainted by other episodes. Our current risk stratification schemes are really based on clinical risk factors. And then this is really important. The different weight of individual risk factors that comprise the score, and the performance varies according to the baseline risk of stroke, which is variable amongst populations. So if you are going to decide whether to anticoagulate with a CHADS-VAS score of 1 or 2 or whatever, you need to understand the risk of stroke in your own population. What will be the role of biomarkers in imaging? And we don't know. Thank you for your attention. I'm sorry about the problem with the slides.